Our next presenter is Dr. Silvia Castelletti from Italy, and she's talking about QT interval. How long is too long?
Thank you very much, and thank you for inviting me. It's a real honor and pleasure to be here, because 12 years ago I was sitting there listening to everyone talking, and now I'm here speaking in front of such a great audience and American colleagues, so thank you very much. So when we speak of QT, we should not just think to a number. The classical cutoff of 440 milliseconds for males and 460 for females may create some overlap between normal and affected people. So we may have 10% of affected persons that are missed with the diagnosis and 10% of overdiagnosed patients. Despite that, it has been noticed in the past that with this cutoff, we may have a higher prevalence of long QT in athletes. And these suggests that the majority of athletes that have a prolonged QT being asymptomatic may have a kind of benign pattern. And this is why in the last years, the cutoff has been changed in athletes, and according to the international recommendation for the ECG interpretation, we use different numbers, 47 milliseconds for male, 48 milliseconds for females. And even in the last ESC sports cardiology guidelines, it is suggested to use this cutoff, and a cutoff of 500 milliseconds is considered diagnostic. However, we know that sometimes there are people that are genotype positive but phenotype negative. And the diagnosis is still important, because we also know that those people with a normal QTc on the surface ECG carry anyway a higher risk of arrhythmic events. So the diagnosis is important. And to help in the diagnosis, we cannot rely just on the number. We should look also to the morphology of the T waves. A large base T wave is typical, for example, of the subtype 1 long QT syndrome. For the type of diphasic and notched T waves are typical, for example, of the type 2 long QT syndrome. And then we may have also late-peaked T waves with a long ST segment that is more typical of the long QT3 syndrome. In athletes, to evaluate the QT is even more challenging, as our athletes display a slow heart rate, may have sinus arrhythmias, may display U waves and wide QRS complexes. So to measure the QT can be quite difficult. In this case, for example, this is an elite athlete with a sinus bradycardia. The QT appears normal as a number. But if we look carefully to the morphology, we can recognize that there is a slight delayed peak of the T wave that should arise some suspicious. So when you are in suspicious, what can we do? The guidelines and the recommendations suggest to perform repeated ECG after some exercise in order to have an ECG with a higher heart rate. My suggestion is to perform an exercise testing and to look to the behavior of the QT during the exercise testing, and most of all during the 4th minute of recovery of the exercise test, as this is one of the criteria for the long QT syndrome diagnosis. So our athlete underwent an exercise testing, and as you can see, the higher their rate goes, the longer the QT becomes. And indeed, a genetic testing was performed, and this showed a pathogenic mutation on KCNQ1 that is responsible for the subtype 1 of long QT syndrome that is associated with arrhythmic events during exercise. Sometimes our athletes may display some U waves, and we may be tempted to use the tangent method that is also suggested by the international recommendation to calculate the QTC. However, if you are in doubt, please look to the whole picture. Because if you use the tangent method, and I'm not saying that you shouldn't use it, I'm just saying look to the whole ECG, you may miss the diagnosis. In this case, for example, as you can see, the QT is prolonged. If you consider all the QT until the end, until the T wave comes back to the ST segment, you will find out that this patient has a prolonged QT, and that the QT interval includes also this part here that you may consider as U wave, but is not. It's part of all the QT interval. Another example, a 21-year-old male with symptoms, with family history. So if you look to his ECG, the QT may appear normal, but first of all, look to the morphology. This is a typical morphology with, these are very, very difficult to notice. There is a notch here. It's very difficult to notice, I can tell you, but if you measure the QT with the tangent, you will find out that his QT is actually normal. It's 457. However, if you consider all the interval until the ST segment, then the QT is much more longer. And indeed, this patient has a mutation on KCNH2. And why that? Because if you use the tangent method, you may lose this last part of the repolarization, that is where exactly the channel act, and when they're impaired, they cause the prolongation. As mentioned, I'm not saying that you shouldn't use the tangent, I'm just saying to look carefully to all the ECG. But not all the QT intervals are equal. So let's go back to our patient. I have already showed you this ECG. He has a prolonged QT, we see that, but also this other guy that has more or less the same age, that is of the same sex, displays a prolonged QT. They both have also repolarization abnormalities as diphasic T waves. So I think that we all agree that both of them have a long QT syndrome based on this ECG. The first patient is asymptomatic. He has been always playing sports. He has no family history. Also, the 24-hour Holter ECG monitoring confirms a prolonged QT interval with, as you can see, diphasic T waves. And indeed, genetic testing was positive. What about the second guy? Same age, same sex. The QT is prolonged. He has repolarization abnormality as well. So, do we all agree that this ECG is highly suspicious for a long QT syndrome? Is there anyone that would say no? No, I agree with you. Also, the 24-hour tape confirms a QT prolongation with repolarization abnormalities. So the patient underwent a genetic testing. A genetic testing came to be negative. In front of this ECG, I think that everyone would have put the patient on medication and started on beta blocker. And this is what we did. We started on beta blocker. He was asymptomatic without family history. He came back for follow-up after 1 year. Look to his ECG. Totally different. He has normalized his basal ECG, And also the 24-hour Holter monitoring shows a normal QT interval. So 2018, this is 2019, sorry, a year. 2018, 2019. What happened? We have learned that there are some athletes that may display a normal ECG when training and then normalize the ECG after the training. We call these the so-called exercise train-induced repolarization abnormalities. We have shown that among a cohort of athletes, of more than 300 athletes, there may be a subset of athletes in which this change can be modified. We saw that there were 121 patients gene positive and with a prolonged QT, so no doubt about the diagnosis. These are patients with long QT syndrome that had a high and prolonged QT, but after the training, their QT reduced, but was still long. Then we had long QT patients with gene negative, in which the diagnosis was clear because also someone else in the family had a prolonged QT with of course, a negative genetic testing, and also then may display a prolonged QT that reduces after the training. But what was striking us was this subset of patients. These were athletes with a negative genetic testing, asymptomatic, without family history, in which, as you can see, the QT was very, very prolonged, was even more long than the one of the patients with a positive genetic testing, that after the train normalized. The cutoff of QT, as you can see, changed greatly between training and detraining. And they were considered normal after the training as they were not reaching the Schwarz score anymore. This is the case, for example, of a young male. As you can see, he was referred by the sport medicine because of this ECG that is clearly an ECG that we would consider as a patient with prolonged QT. And also during our assessment, he was displaying a prolonged QT. However, after the training, he normalized, and when he went back to training, he prolonged again. So when you are in front of a prolonged QT, you should keep in mind that there may be some exception and that sometimes not all the QT are the same. If you are in front of an asymptomatic patient with a negative genetic testing and no family history, keep in mind the possibility that this can be something induced by exercise. My final message, therefore, is that the QT is not just a number. Look to the morphology, look to the family history, personal history, and beware that sometimes we should not judge by the appearances. So if you're interested in the topic, please come and join us next year at the EAPC. I will be more than happy to host you in Milan. Or otherwise, please take part to the sports cardiology master that Michael organizes every year. Thank you very much.
Thank you, Sylvia. Any question?
Ask a question first. It's going to be.
Thank you. Excellent presentation. The concept of repolarization reserve. We know from non-athletes, repolarization reserve, for instance, patients have could have QT prolongation with drugs in non-athletes. And when challenged, those patients are predisposed to arrhythmias. These athletes with the QT prolongation, that on training, they normalized, to me, that's a repolarization reserve. Are these athletes still predisposed, and should we be avoiding drugs that can cause QT prolongation in these athletes?
Yes, I think so, of course, because I think that this means that these athletes have a predisposition for a QT prolongation. So as exercise acts as a trigger for a QT prolongation, I think they should also avoid drugs that may prolong the QT. About the risk of arrhythmias, we are unsure whether they have a higher risk of arrhythmias. So to be fair, I wouldn't stop them to exercising, but I will perform a strictly follow-up. And if the QT is very prolonged during training, I may suggest to not exercise actually and be on the safe side.
Hi,
Thank you,
for
Sylvia.
your presentation. Just a practical question. I'm an interventional cardiologist, not a sports cardiologist. How would you define training and detraining in terms of METs?
Well, I use the international criteria for training and detraining, and but actually to see a real change in DCG after the training, you should stop from exercise completely, at least for 3 months. But this varies a lot by athlete to athlete.
Thank you. We have no time for more questions. Sorry.